Hello everyone, welcome to Pediatrics and Neonatology. This video is about abdominal migraine. Abdominal migraine is described as paroxysmal disorder of an acute onset. It is a severe, non-colicky periumbilical abdominal pain which is accompanied variably with nausea, vomiting, anorexia, headache and pallor. It occurs mostly in children and the mean onset is at age 7 years. Peak symptoms occur around 10 to 12 years of age. It is more common in girls. It may affect as many as 1 to 4% of children at some point in their lives, and there is a declining frequency towards the adulthood. Now, there are some genetic risk factors, and parents of affected children often have history of migraine headaches and motion sickness. Abdominal migraine may involve neuronal activity originating in the hypothalamus, along with the involvement of cortex and autonomic nervous system. Now, serotonin is implicated, and blockade of serotonin receptors may prevent abdominal migraine. Recent studies also suggest involvement of local intestinal vasomotor factors in abdominal migraine. Now, diagnosis of abdominal migraine require Rome 3 criteria. This include 2 episodes which should occur within 12 months, meeting all the following criteria: paroxysmal intense periumbilical pain that lasts more than 1 hour, intervening episodes of health between the episodes, pain that interferes with the activity, pain associated with 2 or more than 2 of the following: anorexia, nausea, vomiting, headache, photophobia or pallor. Then no evidence of inflammatory, anatomic, metabolic or neoplastic process, and no evidence of elevated intracranial pressure, that is tumor or hydrocephalus. Now in the history, ask about family history of migraine headache or unexplained bouts of abdominal pain as children. The pain of abdominal migraine typically lasts less than 6 hours, and generalized abdominal pain because of some other reason can be localized to upper quadrant. Now in abdominal migraine, there is no abdominal pain between the episodes, and there is repetition of identical abdominal crises anywhere from 1 time per week to several times a year. Now also ask about the history of migraine in patient or relatives, and also inquire about migraine phenomena such as nausea, vomiting, perspiration, body temperature changes, focal paresthesia, radiation of pain to a limb, visual disturbance or general malaise. Also ask about associated fatigue, lethargy or impairment of consciousness. Physical examination should include complete neurologic and abdominal examination, and in abdominal migraine it is unremarkable. Complete eye examination including fundoscopic examination should also be done to evaluate for papilledema. This is due to elevated intracranial pressure in case if there is tumor or hydrocephalus. Now the diagnostic test and interpretation. Abdominal migraine is a diagnosis of exclusion. Even if a patient meets most or all the diagnostic criteria for abdominal migraine, following studies should be strongly considered to ensure that another serious disorder does not exist. These include complete blood count with differential, erythrocyte sedimentation rate, and C-reactive protein, urine analysis, pregnancy test, amylase and lipase, stool hemoccult, stool culture, lactose breath test for lactose intolerance, lead test, evaluation for porphyria or familial Mediterranean fever, and metabolic evaluation obtained during symptomatic episode and not during quiescence. This include urine organic acid, plasma amino acid, ammonia, lactate, blood gas, acyl carnitine profile and imaging. Then there are some diagnostic procedures which should be done in the case of abdominal migraine. These include obstruction series to assess for intermittent or partial bowel obstruction, upper GI series to rule out anatomic abnormalities, ultrasound or CT scan to rule out mass lesion or chronic appendicitis, renal ultrasound during the episode to rule out uretero-pelvic junction obstruction, then barium enema during the painful crisis to rule out intussusception. EEG may help differentiate between abdominal migraine and epilepsy. Visual evoked response to red and white flashlight Children with abdominal migraine may display a specific fast wave activity response, and rarely brain imaging with CT scan or MRI. This may be useful for evaluating causes of intermittent hydrocephalus. Now, here are some conditions which should be considered in the differential diagnosis of abdominal migraine. These include infections such as giardia, lead intoxication, tumors, metabolic conditions such as porphyria, lactose intolerance, female carriers of X-linked ornithine transcarbamylase gene mutation, and organic acidemias. Psychosocial conditions such as functional abdominal pain or irritable bowel syndrome. Surgical conditions such as appendicitis, intussusception, and biliary colic. Inflammation such as inflammatory bowel disease, peptic ulcer disease, mesenteric adenitis. GIT differentials include gastroesophageal reflux, wandering spleen, cyclical vomiting syndrome, recurrent abdominal pain, functional abdominal pain, constipation, superior mesenteric artery syndrome, and recurrent pancreatitis. Anatomic conditions include Meckel's diverticulum and uretero-pelvic junction obstruction. Now, an important neurological differential is abdominal epilepsy. This has a shorter duration of pain and there is altered consciousness during the event. There is also abrupt onset and abnormal discharges in the EEG in 80% of the cases. Other differentials are temporal lobe epilepsy and intermittent hydrocephalus. Now, because abdominal migraine is a diagnosis of exclusion, many patients go through a long workup to rule out other causes of pain, and sometimes this includes laparotomy. Now, the treatment of abdominal migraine. Medications can be used to abort acute attacks or can be taken as daily prophylaxis. For most patients, risk of side effects and complications from the use of these medications may outweigh the relief of pain, especially in children who are experiencing infrequent episodes. Now, limited data exist on abortive agents for the abdominal migraine. However, several agents have shown benefit in specialty-based clinical practice, and these include metoclopramide, steroids, intranasal sumatriptan, and non-steroidal anti-inflammatory drugs. Although the latter may be avoided if there are clinical concerns for gastritis or peptic ulcer disease. Consider benzodiazepine, for example lorazepam, and antiemetics, for example ondansetron, for vomiting predominant symptoms. Now, suggested prophylactic treatments are similar to those for the migraine headaches, and this include tricyclic antidepressant, for example amitriptyline, topiramate, propranolol, cyproheptadine, and valproic acid. If EEG or other data point to possible epilepsy, then empiric treatment with anticonvulsant may be considered. Now, additional therapy include trigger avoidance. An event diary should be kept to identify possible migraine triggers. Avoiding triggers is the most optimal strategy for the prevention of recurrent attacks. Common triggers include caffeine, nitrites, amines, emotional arousal, travel, prolonged fasting, altered sleep, exercise, and flickering lights. Now, another additional therapy is cognitive therapy. This includes behavior therapy and lifestyle modification, which include regular sleep, hydration, and exercise, and these are beneficial. Biofeedback in conjunction with other cognitive therapy and relaxation program may also be helpful. Now, assistance from a trained pediatric mental health professional may be useful. Now, most children outgrow abdominal migraine symptoms by early adolescence. A substantial percentage of patients, about 70%, may develop more typical migraine headache during adulthood. Although non-specific EEG changes are seen more commonly in this condition, very few children go on to develop epilepsy. 10% of the children who have a diagnosis of migraine headaches have previously suffered from unexplained recurrent abdominal pain. And adult migraine headache sufferers experience abdominal pain more frequently than do tension headache sufferers. Now, to help child during the bouts of pain, allow the child to do whatever makes him or her comfortable. That is rest, positioning, and being quiet. Now, whether the patient should be excused from school depends on various factors. These include frequency, severity, and duration of pain, age, maturity, and coping skills of the child. Okay friends, thanks for watching. Please like, share, comment and subscribe to my YouTube channel for more informative health videos.